The Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policy, Maternity Staff Training Program, If the Baby Cannot Feed at the Breast, Session 12. Objectives. Ideally, babies should receive their own mother's milk directly from the breast through suckling. However, the ideal situation does not always occur. In this session, we will cover reasons when supplementation may be medically indicated. Keep in mind that supplementation refers to situations where direct breastfeeding, nursing at breast, cannot be accomplished. In many cases, feeding at breast while using other methods can be achieved without interfering with the breastfeeding process. We will discuss various methods along with ways to express milk. On occasion, a mother and baby may be separated for a medical reason due to a serious illness or hospitalization. This situation may require the establishment and maintenance of the mother's milk supply so the infant can temporarily or permanently receive a supplement. There are only a very small number of conditions for both the mother and the infant that avoidance of breast milk may be justified and the use of a non-breast milk substitute needed. According to the World Health Organization, infants with galactosemia or maple syrup urine disease should not receive breast milk and only receive a specialized formula designated for their condition. Infants for whom breast milk can be provided but may also need an additional supplement are very low birth weight infants, less than 1,500 grams, and infants born prior to 32 weeks gestation. These infants may require additional supplements, but only for a limited period of time. Maternal conditions that require permanent avoidance of breastfeeding are mothers with HIV infections or mothers who cannot abstain from the use of illicit drugs. Conditions that justify temporary avoidance of breastfeeding until the condition resolves are maternal illnesses that prevent the mother from caring for her infant, a mother with herpes simplex type 1 lesion on her breast that her infant's mouth will come in contact with when breastfeeding, or the use of a medication that's contraindicated and a safer alternative is not available. Other situations that may require additional supplementation with breastfeeding would be a mother who cannot produce enough milk for her infant. Mothers with insufficient glandular tissue or those who have had breast surgery that damage the glandular function may need to supplement. As always, when a supplement is needed, a mother's own breast milk is the first choice unless contraindicated. When the biological mother is unable to provide milk for her baby, the World Health Organization's first choice of a supplement is banked donor milk. In the hospital setting, policies and guidelines need to be established to be able to provide donor milk from a licensed milk bank. During the hospital stay, it is imperative to establish the milk supply. When a mother is unable to do so fully by nursing her infant at breast, expressing her milk, in addition to nursing at breast, helps to establish and maintain her milk supply. Separation of mother and baby often creates the need for breast milk expression. In the hospital, separation due to illness of either the mother or infant is one of the main reasons to initiate milk expression. In some cases, the baby and mother may be cared for in different hospitals, or one is physically incapable of her role in lactation. The short and long-term outcome of the sick and preterm infant depends heavily on the early postpartum management of the mother's milk supply. Delaying to initiate feedings or effective expression of milk by waiting more than 6 hours postpartum may permanently compromise a mother's future milk production potential. The most critical determinant of post-discharge breastfeeding, with all the associated health and developmental benefits, is the early establishment of a robust milk supply, defined as greater than 600 milliliters a day by 2 weeks. Any time a mother and baby are separated and cannot initiate breastfeeding, expression needs to begin within 6 hours of delivery. Once home, separation most typically results from a mother returning to work or school although a mother may also voluntarily request separation, perhaps to go out for a few hours. Expressing breast milk during these instances allows for continued stimulation and maintenance of the mother's milk supply, which in turn allows for the infant to exclusively receive breast milk. All mothers should be taught how to hand express their breast milk. Mothers that are taught to hand express often become so efficient that they find it easier and faster than using a breast pump. Hand expression is an essential backup for times when a breast pump is not functioning properly or a power source is unavailable. Breast pumps are available in many different styles. The most important thing to remember is that not all pumps are equal in performance. Mothers should be encouraged to use a pump from a company that has done testing to ensure pump safety and effectiveness. Hospital-grade pumps are closed-system pumps that allow for use between patients and are the strongest and most effective pumps to use when a mother and baby are separated. Most other pumps are open systems that are intended for single-person use, since there is potential risk for milk to come in contact with parts that cannot be cleaned. If a mother is returning to work and will need to pump frequently, a hospital-grade rental or personal use double electric pump would work well. Battery-operated pumps and hand pumps are best used for the occasional or infrequent pumping. Evidence has shown that mothers that combine pumping with hand expression and breast massage obtain more milk during pumping sessions than mothers who just use the pump for breast stimulation. Hand expression is a valuable and important skill for all breastfeeding mothers to learn. First and foremost, it allows for milk to be expressed, even if a pump is not available. Many mothers feel they don't need to learn hand expression and instead plan to use a breast pump. However, pumps can break, parts can be missing, or an unavailable power source can leave the intended pump inoperable. Some mothers even find that, to their surprise, once they've mastered hand expression, they prefer it over electric pumps. Teaching the mother to hand express while in the hospital and collecting just a few drops of milk emphasizes the value of each drop, especially since colostrum, the first milk, is small in volume. Even just a drop or two can be used by small newborns to impact a low blood sugar and avoid formula supplementation. Sometimes hand expressing a few drops onto the breast entices a baby to successfully feed when latching has been difficult. Premature babies typically feed on just 1 or 2 milliliters for their initial feedings. This further emphasizes the importance of just 1 or 2 drops. Hand expression is a skill that healthcare professionals who work with breastfeeding women need to learn and be able to teach to mothers. It is a skill that will take practice to learn, but once mastered, will aid in latching. In this video, you will learn hand expression from one of the experts in the field, Dr. Jane Morton, a pediatrician. She was the director of the breastfeeding medicine program at Stanford University, executive board member of the American Academy of Pediatrics section on breastfeeding, and a fellow of the Academy of Breastfeeding Medicine. She teaches breastfeeding management strategies to her patients and other healthcare professionals. More of her videos and educational materials can be found at Stanford University's website, www.newborn.stanford.edu.
The breasts operate on a supply and demand system. In the first few days, effective removal of the small aliquots of available colostrum on a regular basis stimulates production. Many babies who are with their mothers need help and time before learning to effectively breastfeed. Hand expression and spoon feeding after each breastfeeding can provide more stimulation to the breasts and more milk for the baby than breastfeeding alone. Mothers who are separated from their babies need to begin pumping within hours of delivery. Some mothers find it difficult to remove colostrum with an electric pump. In the first 3 days, using both the pump and hand expression can increase later milk production. This mother is learning to hand express for her 1-day-old son, born at 28 weeks gestation. A 1 cc vial works well for both collection and transportation of the milk to the intensive care nursery. A new mother who can effectively express small volumes of colostrum into an appropriate sized container and watch it being given to her infant can better understand the important protective role only she can provide for her baby. It is very simple to learn and teach hand expression. In the first couple of days, the average size of a good breastfeeding for a term baby is only a teaspoon. So all we expect to express each session is a few drops to a teaspoon. The more frequently milk is expressed, the sooner milk comes in and the more milk is produced. Partners can help if mothers are too sick. Mothers may find the following suggestions helpful. Have the mother sit up so that gravity is working for her, not against her. Use gentle massage over the breast with hands, a soft baby brush, or a warm towel. It'll help get the milk beginning to flow. Already we can see just with that.
Oh yeah.
That just the massaging. Exactly. That's really good. Place fingers an inch away from the areola, making a C. Band-Aid markers make it easy to remember finger placement. I'm not going to get my fingers down here with a C. I'll keep them here so that the nipple is in the middle of my thumb and my pointing finger. Apply steady pressure inward towards the breasts, never massaging outward towards the nipple or the spoon. So back and then very gently together, and back and very gently together, and I don't expect to see anything in the beginning. So just know that in the very beginning, even when the baby nurses, she doesn't get anything. She's just beginning to sort of stimulate the milk to let down. And then, and the reason I just go very gently is so your breasts get kind of used to it first. And rather than stay on one breast, I go back and forth. So I go from the right to the left and right to left and back and forth. When I push back, I don't tighten up the skin, the dark skin. I don't pull like this. I just go straight back and together, and straight back and together. And then we'll get the milk flowing a little bit, and then I'll show you how to do it, and then we might as well start collecting a little bit.
Yeah, sure.
So remember, when you try to do this yourself, that in the beginning the milk didn't come very easily, and now it's coming very easily. Okay? Think of press, compress, relax. Press, compress, relax. In contrast to the breastfeeding baby, who, with her tongue and jaw, massages the ducts beneath the areola, with hand expression, we apply compression further back and deeper into the breast tissue. Press, compress, relax. Press, compress, relax. You make your hands really, really relaxed, and I'll do it for you. And I'll push back, and then we'll come together. And we'll push back and come together. And then relax totally, push down, and come together. So it's sort of press, compress, and relax.
Okay.
Press, compress, and relax. Go back and forth from right to left to right to left. By alternating sides, the bursts and pauses of milk expression simulate the normal pattern of suckling of a baby. Avoid tightening or stretching the skin over the areola. Think of almost pooching it together, then push back,
Okay.
and then come together.
Oh, yeah.
You see, if you tighten it, it doesn't, think of it the way it's inside a baby's mouth. If you make it a little bit looser like this first, and then kind of push down and come together. I think you'll find that it comes out a little bit more. If I tease back like this too much, then I suppose I'm blocking the ducts.
So first you pinch,
yeah,
then you press,
and then come together. That works a lot better, doesn't it? Develop a rhythm, like a baby nursing. That is just perfect.
Wow, that's a lot.
The more frequent hand expression is used, the easier it becomes, the earlier milk comes in, and the more milk mothers will make. Mothers who are separated from their babies have been shown to produce 80% more milk by using hand expression more than 5 times each day in the first 3 days, in addition to using the electric pump. Always think of pushing back. There, a girl, pushing back. And then kind of that last little pinch together. The vials or syringes of milk can be collected in a cup of ice and taken to the nursery for the baby. After every breastfeeding, hand express and feed this to the baby from the spoon when she is propped up. The more milk a mother has, the easier for the baby to effectively breastfeed.
Expression can be aided by relaxation and breast massage in helping to elicit an effective milk letdown. Always start by having the mother wash her hands. Gently massaging both breasts and manually stretching the nipples by hand can facilitate milk flow. Moving the fingers in a gentle circular motion from the outer edges of the breast and working toward the nipple will help move milk forward. Having a mother listen to relaxing music, practicing deep breathing learned during childbirth, smelling a piece of her infant's clothing, or visualizing images of waterfalls can often be helpful. Have the mother place her hand with her thumb and index finger on opposite sides of the outer edges of the areola. Press the hand inward toward the chest, not outward toward the nipple. Then compress the finger pads together. Repeat this action in a rhythmic pattern, and each time bring the finger pads slightly closer together. A tighter compression as tolerated without pain. After 10 to 20 compressions, switch to the other breast, then back to the first, then back to the second again. Rotate the hand in different positions to compress along the entire circumference of the areola. Do this despite the presence or absence of colostrum. When teaching or demonstrating with a mother, be sure to collect any drops expressed. This can be done on a teaspoon or in another clean container. When breast milk expression is needed in the hospital setting, the preferred pump to use is a hospital-grade double electric pump. The closed system of a hospital-grade pump allows for use between patients and provides the maximum stimulation needed in initiation of a milk supply. Staff members responsible for caring for mother-baby dyads should be trained in the assembly, cleaning, and function of breast pumps used in their facility, following the manufacturer's instructions. Never use a pump on a mother that is not functioning correctly, and always follow your hospital policy and procedure for use of all medical equipment. Provide the mother with clear instructions on how to assemble her pump, use it, store her breast milk, and clean all the pumping equipment. Remember, this is a stressful time for new mothers, and they may need instructions repeated on the pumping procedures. Research has shown that mothers that hold their babies skin to skin, even if they are unable to breastfeed directly from the breast, produce more milk. Encourage skin to skin as soon as the mother and baby are able to tolerate it. Some mothers may benefit from a pumping log or app to help them keep track of pumping sessions. Mothers who need to pump in the hospital should initiate pumping within 6 hours of birth when the mother or infant are unable to physically breastfeed. Mothers should be taught to pump 8 times in a 24-hour stretch, with each session lasting 15 to 20 minutes in length to maximize stimulation to the breast. Teach the mother how to alternate between pumping and hand expression to maximize output of milk production. Teach the mother that even just a few drops of her colostrum is important and can be used for mouth care with her infant even if he's not feeding yet. Familiarize yourself with your facility's policies on pumping and storage of breast milk. Teach mothers before breastfeeding or expression of breast milk to always start by first washing their hands. Thorough hand washing reduces the potential for and degree of contamination of expressed milk. A clean pump kit will be needed before starting to pump. Most hospitals purchase pump kits that come pre-sterilized, so no washing is needed with the first use. Use a separate wash basin, not the sink, to wash all parts. Sinks are more likely to be contaminated. Read the manufacturer's information for cleaning instructions and type of soap to be used when washing pump parts. Dish soap may need to be provided to the mother to wash parts while still in the hospital setting. Contact your infection control department to help with providing the safest, cleanest way for a mother to clean her pump parts. Always refer to your hospital's policy and procedures for cleaning of pump parts and hospital equipment. If the mother is pumping at home and bringing milk to the hospital, most pump parts can be cleaned in a dishwasher for easy at-home cleaning. Breast preparation or cleansing is usually not needed. Normal hygiene is usually sufficient. Elaborate protocols for breast cleansing are unnecessary and may cause damage to the nipple skin by causing it to dry and crack. Gloves are unnecessary when handling breast milk. The only situation where gloving is warranted is when handling human milk in a donor milk bank setting. Human milk is not listed as one of the body fluids of concern in the OSHA standards. However, some NICUs practice universal precautions no matter what the body fluid is. If it is policy to glove when feeding an infant human milk, it should be looked at in terms of protecting the milk from contamination by the person who is preparing or feeding the milk. Milk storage guidelines will vary depending on the gestational age of the infant and storage ability of the facility you work in. These recommendations for milk storage are from the Human Milk Banking Association of North America and were developed as a guideline for clinicians to follow using evidence-based research or expert opinions when no research was available. Storage and handling of breast milk will vary depending on the age and health of an infant. It is important that mothers learn how to handle and store their milk to decrease the risk of contamination. Safe storage will also help to preserve the quality and storage life of the milk. Mothers will also need to know how to properly store their milk in the refrigerator and freezer and also how to transport it. Suggest that a mother begins by storing her milk in small quantities to eliminate waste when defrosting. For healthy full-term babies, milk can be stored in 2 to 4 ounce quantities. For premature infants, store milk in even smaller quantities to avoid wasting any milk. Milk stored in soft polyethylene bags or bottles loses some of its nutritional and immunologic properties. Mothers of premature infants or sick infants should be encouraged to use containers that preserve as much of the milk quality as possible. All milk for use in the hospital should be labeled with 2 patient identifiers to avoid errors in identifying an infant's milk. Most hospitals will use printed labels with the baby's name and second identifier, such as medical record number, birth date, or mother's name to correctly identify milk. The mother should add to the label date and time the milk was pumped. Make sure that the mother labels her milk as soon as it is pumped to avoid errors in labeling. When using pump breast milk in the hospital setting, staff should perform a 2-person check or have a milk scanning system in place to identify that the correct milk is being given to the correct infant. Check to see that your hospital has a policy in place for milk identification and one for patient safety when errors occur. Teach the mother to store her milk in the back of the refrigerator or freezer to prevent temperature fluctuation from frequent door openings. When transporting her milk, she will need to make sure to pack the milk in a cooler bag for travel with plenty of ice to prevent milk from warming or defrosting if frozen. If the mother is planning to add new milk to a container of frozen or chilled milk, she will need to chill the milk first before adding it to avoid thawing or warming of her previously pumped milk. It will be important to teach the mother to always use the oldest milk first to prevent milk from going past its recommended storage guidelines. There is very little research on thawing of human breast milk. Experts in the field recommend following food safety guidelines and handling thawed milk like other foods. Breast milk can be thawed in a waterless milk warmer, warm water bath, or at room temperature. Recent research on milk temperature for feedings suggests that milk be warmed to body temperature to reduce the risk of necrotizing enterocolitis in premature infants. More independent research is needed, but many hospitals have started to use waterless milk warming systems to ensure safe thawing and warming of milk. When using a water bath, care must be taken to not over or underheat the milk or allow the water to seep under the lid. Never microwave breast milk or refreeze thawed breast milk. Once milk is warmed, it should be used immediately, and anything that's not used, discarded. Express breast milk will separate, and once thawed or warmed, will need to be gently remixed to evenly distribute the fats and proteins in the milk. When thawing a bottle of milk, the entire bottle will need to be defrosted and remixed before using. Never attempt to pour off milk from a partially defrosted bottle. Most mothers of newborns produce enough milk to provide all the milk their babies will need. However, a mother may be unable to provide enough milk for her baby, or she may be medically unable to provide milk for her baby. Especially for the very sick or very premature infant, human milk can mean the difference between life and death. For these babies, donor milk is a safe alternative and recommended as the next best choice when baby's own mother's milk is not available. Hospitals will need to develop a donor milk policy to ensure safe handling and milk donation. Donor milk from a certified milk bank ensures that milk donors are screened and that the milk has been pasteurized to destroy any objectionable organisms that would be unsafe. For premature infants and other infants in need of special care, human milk provides the best protection against devastating infections. When a baby cannot feed directly from its own mother's breast, there are alternative feeding methods that can help preserve the breastfeeding relationship while providing nourishment for the infant. These methods offer time and opportunity for the infant to learn how to latch onto the breast directly while learning to transfer milk on her own from her mother's breast. Anytime an alternative feeding method is implemented, the plan of care should include follow-up with a board-certified lactation consultant to monitor the infant's intake, tolerance to the feeding method, maternal milk supply, and readiness to feed directly at the breast. Tube feedings refer to the use of a nasogastric or oral gastric feeding tube used when an infant is unable to suckle and/or swallow on its own to gain nutrition. These are often seen in the hospital setting with premature infants until the infant can feed on its own. Cup feedings are a good alternative to use when babies are able to swallow but are unable to suckle well enough at the breast to obtain an entire feeding, or while the mother is too ill or has a medical condition that prevents her from directly breastfeeding. These are used when breastfeeding is interrupted or a supplement is needed when breastfeeding is insufficient. A cup feeding avoids the use of artificial nipples, is inexpensive, and easy to use. It does not satisfy the infant's need to suck, nor does it assist with the development or improvement of breastfeeding. Cup feedings are a short-term alternative since some full-term infants can develop preference to the cup feedings if not going to the breast frequently. To cup feed, sit the infant semi-upright or upright on a lap while supporting the back of the neck and head. Use a small cup, filling it only 1/4 to 1/2 full. Hold the cup slightly against the infant's lower lip, tipping the cup so milk just slightly touches the lower lip. Do not pour the milk into the infant's mouth, but rather allow the infant to open its mouth and start taking the milk in. Some infants will lick the milk, while others will start sucking the milk into their mouths. Syringe feedings or syringe finger feedings can be either given using an orthodontic curved tip syringe or a syringe with an oral feeding tube attached. It is never recommended to alter a piece of medical equipment or use equipment other than what it was designed to be used for in the hospital setting. Using IV tubing or cutting feeding tubes is not recommended. Syringe or finger feedings are best used for giving supplementation when a baby is able to latch well, but needs to improve sucking skills or is unable to transfer the needed milk. When syringe feeding at the breast, insert the tip of the syringe or feeding tube just inside the infant's lips at the corner of his mouth. Give only small amounts of milk when the infant sucks, if the infant is sucking correctly, and a good seal is formed. Often the infant will regulate the flow and draw the milk from the syringe on its own. When using a finger to provide the syringe feeding, hold the infant in a semi-upright position supporting the back of the neck and head. Parents may use an ungloved, clean, well-trimmed, polish-free finger, while hospital staff should always wear gloves. Using the finger, stroke the infant's lips to elicit a rooting reflex or opening of the mouth. Then place the finger into the infant's mouth, pad side up, and straight into the depth of the junction of the hard and soft palates as the baby tolerates. Slide the syringe or tube into the infant's mouth alongside the finger, or if using a tube, tape can be used to hold the tube in place on the finger during feedings. As the infant sucks, reward sucking with a small boluses of half ml or less of milk. A spoon feeding is ideally used when only a small amount of milk is needed to be fed back to a baby or needed to help initiate a breastfeeding. If more than a tablespoon or two is needed, one of the other methods would be better suited. Spoon feeding is an excellent way to deliver express colostrum, as it is inexpensive and the equipment easy to come by. As with a syringe feeding or cup feeding, the baby needs to be placed in an upright position with the head and neck supported and fed in the same manner as a cup feeding. The Supplemental Nursing System, also known as SNS, is a device made up of 1 or 2 feeding tubes connected to a bottle containing milk. The tubing is taped on the mother's breast so that when the baby is latched on, the tube lies within the baby's mouth. As the baby nurses, milk is drawn from the bottles as well as from the breast. Often, this encourages a baby to suck harder and nurse longer with the reward of more milk. The additional suckling at the breast, in turn, helps to stimulate the mother's own milk production. This device is typically used when long-term supplementation is going to be required because of either an infant's inability to remove enough milk while at the breast or a mother with a low milk supply. The supplemental nursing system is only useful if an infant is latching at the breast well. It is, however, more expensive than other alternative feeding options and may be viewed as cumbersome and labor-intensive by some parents. As with any alternative feeding device, the goal is eventually to remove the need for the device with the baby being able to accomplish full, exclusive feedings at the breast. Whenever alternative feeding devices are in use, a referral for daily follow-up with a board-certified lactation consultant during hospitalization is recommended, with weekly follow-up for evaluation and assessment once discharged. Anytime devices are used, mothers can become overwhelmed and discouraged with not being able to provide breast milk fully from the breast for their infants. Remind the mother that the infant may just need a little extra time to learn this new skill, and our goal is for her to eventually be able to fully breastfeed her infant without the need for a feeding device. In conclusion, there are medical reasons when babies may not be able to feed at breast. These babies can still receive the benefits of breast milk by receiving their mother's own expressed milk or donor human milk. You've also learned about different methods for feeding expressed milk to infants.